In the United Kingdom, if a patient receives an allograft, even a small piece used in a dental bone graft, they can no longer donate blood or organs. That same material, though, is legally used in thousands of dental and surgical procedures every year. Meanwhile, in other countries, allografts are restricted or completely banned because of health risk concerns, mainly the fear of disease transmission. So how can the same material be both approved and prohibited depending on where you work? Let's explore what dental allografts really are, why they raise safety debates, and when their benefits might outweigh the caveats. This channel explores implant and oral surgery, how the body responds, how we can improve healing, what the science shows, and how disciplined surgical execution turns evidence into results. Welcome back. Allografts come from human donors, usually via licensed tissue banks. They are used for socket preservation, ridge augmentation, sinus lifts, and all sorts of different bone grafting approaches we do in dentistry nowadays. Processing removes living cells to lower immune response, but keeps the bone matrix that acts as a scaffold. There are two common types: the freeze-dried bone allograft, mainly osteoconductive, and the demineralized freeze-dried bone allograft, with some osteoinductive potential because it retains bone morphogenic proteins. The goal is to provide a framework that host bone can remodel into living tissue. Now, why some countries restrict them? Concerns focus on infectious disease. Even though the probability is extremely low, it is not zero. Pathogens such as HIV, hepatitis B and C, and prions linked to variant Creutzfeldt-Jakob disease, the mad cow disease, are the main worries. Prions are resistant to heat, chemicals, and irradiation, which explains why some regulators prefer a total ban. In the UK, allografts are permitted under the Human Tissue Authority following strict donor screening and traceability. In France, part of the Middle East, in some Asian regions, they are restricted or banned, usually for infection control, ethical or cultural reasons. Now, how safety is achieved? Modern tissue banks use multi-step protocols, donor medical and social screening, laboratory tests for viral and bacterial diseases, chemical cleaning to remove residual proteins, gamma radiation or freeze drying for sterilization, control storage with validated monitoring. But sterilization has a trade-off. Excessive irradiation above roughly 25 kg reduces osteoinductive proteins such as BMPs, bone morphogenic proteins. Too much safety processing can reduce biological performance. Finding the balance between sterility and bioactivity is critical. Even acellular allografts aren't invisible to the immune system. Residual donor molecules can trigger a mild macrophage response. When the response polarizes towards M2 macrophages, healing is smooth. These are the macrophages that lead the healing. If M1 macrophages dominate, inflammation slows regeneration. Allografts remodel faster than xenografts, but may resorb more quickly. Mixing them with autogenous bone or PRF often gives more stable results. Let's have a look at some clinical benefits now. There's no donor site morbidity. There's consistent supply from regulated tissue banks, easy handling and contouring, strong evidence base for socket preservation, GBR and sinus grafts. Multiple systematic reviews show that well-processed allografts perform comparably to autografts for bone fill and implant success, provided case selection and surgical technique are sound. Now let's have a look at risks and caveats. Residual infection risk. It's minimal, but not zero. Reduce bone morphogenic protein content after heavy processing. Different legal status between countries. Ethical or religious objections in some patients. Variable immune reactions depending on host biology and on manufacturing process. Because of these caveats, informed consent is mandatory. Always explain what an allograft is, its origin, what alternatives exist, xenografts, autografts, synthetic options, etc. And patients need to understand that in some countries, like in the UK, they're not allowed to donate blood or organs. So allografts are not black-white. They represent a careful compromise between science, safety, and ethics. Used correctly from accredited banks under proper regulation and with transparent consent, they can be an excellent tool in regenerative dentistry. So before you use one, ask yourself 3 questions. Is it legally compliant where I practice? Is the graft biologically sound for this indication? Does my patient fully understand what they are receiving and what the limitations are? When biology, regulation, and ethics align, predictability follows. Thank you for watching. Please like and subscribe.